Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this education episode, we're talking about something that has become, I would say, pretty popular the last decade or so, and that is Femoroacetabular Impingement.
And if you haven't heard, this episode is eligible for free CEUs for Certified Athletic Trainer, and we have bonus content on this episode and bonus CEUs that are available for purchase at precisionat.com/home-study-CEUs.
Yes, thank you so much to Precision AT for making that possible.
Awesome. So what are we going to talk about today, Randy?
Yeah, so our objectives are we're going to describe the pathophysiology of femoroacetabular impingement, or FAI. We're going to discuss the evaluation process for suspected FAI, which, after going through my reading, I found out is actually more difficult than you think.
Okay, I'm intrigued.
I know, we'll talk about it later. And then we're also going to analyze treatment options for patients with FAI.
And what does the bonus content look like?
So the bonus content is we're going to talk about some special tests that are used for trying to identify FAI, and we'll go over some like rehab exercises that might be some good options that are evidence-based.
Awesome. I cannot wait to be the subject.
Yes, that's true. That's right. You will be.
So let's start with the pathophysiology of FAI. Isn't that everyone's favorite topic to talk about?
Of course. So I was pretty proud of putting this together. I kept it nice and simple with what is FAI. I feel like we should just establish that.
Yes, please tell me.
So the definition of FAI is it's an impingement created by bony malformation on either the femur, which would be the head-neck region of the femur, the acetabulum, or it could be both.
So can you figure this out just through an x-ray?
It is possible, yes, and that is one of the criteria that they use to diagnose FAI is via x-ray, but sometimes you need more advanced imaging sometimes too.
Because remember, that's what they did to me.
Yes, they did.
I do not have FAI, at least not bony FAI.
Yes, that's true.
But if I did, what are the different types that we might see? Yeah,
so depending on the region where it is, it has a different name. So a cam lesion is when the bony malformation is on the head-neck region of the femur. A pincer FAI is when that bony malformation is on the acetabulum. And don't worry, it gets even more complex as they just name it mixed when it's lesions on both structures.
Oof, that doesn't even sound good.
Yeah, I feel like that would just be terrible. But you know what I found that was interesting as I was kind of reading along was cam lesions tend to be more prevalent within the literature compared to pincers or mixed.
So cam is in like on the head neck region.
Exactly, on
the femur. So like the femur is pointier than like the acetabulum.
Yes.
Huh.
Or more pointy than the other, like the unaffected leg.
Interesting.
Right? I thought it was very interesting.
Which I mean, that to me kind of makes sense because when I think of FAI, the femur is really what's moving the most. The acetabulum is a lot of times the more stable structure.
Yeah, definitely. And it also kind of makes sense when a lot of the reasons they're thinking this is happening is as adolescents are developing, they're participating in more high-impact sports that involve a lot of cutting and stuff, and that's involving a large load through the femur. So it kind of makes sense.
Got it. Okay, so what's the big deal about FAI?
I wrote that as the title, and I was pretty proud of it. I was like, man, what's the big deal? Let's talk about it. So the reason FAI is a problem, besides obviously if you have impingement, it could cause pain, but also there is a component of people that are asymptomatic as well. But the real issue with FAI is this premature contact between the femur and the acetabulum because of this, overgrowth can create shear forces across the femoroacetabular labrum and the articular cartilage of the femur and acetabulum. So essentially what's happening is as you move and those two or that bony overgrowth contacts the other bone, you still have to create movement somehow. So the femoral head's going to try and achieve whatever movement you're trying to do, and that creates that shear force against the cartilage. Well, repetitive shear forcing, which if we've learned anything over the years, is how bad shear force is.
you first say that, the first thing that comes to my mind is ACL.
Exactly. See? Shear force, evil. I think that's the bottom line right there.
Done. Episode done.
But this shear force creates micro trauma. So the cartilage is getting damaged slowly at a time. And there's actually evidence that this micro trauma is present in the cartilage. They've shown in those with FAI that they have an inflammatory response in the articular cartilage, which, as we know, inflammation is needed to heal. So it makes sense if there's trauma, there's going to be inflammation. What's very interesting is this response within the cartilage has been shown to be a precursor to the same inflammatory response to those with hip osteoarthritis.
Wait, what? So break that down.
So when they break down, or when they look at like the inflammation within the cartilage, like through like histology and all that fun stuff, the inflammatory like precursors, like signs that like this inflammatory process is going to keep going, that it's going to start degrading, is the same as in those with hip osteoarthritis. So what you're seeing is those with FAI have a higher chance of eventually developing osteoarthritis.
I mean, it makes sense if you have more contact on that joint.
And the reason for this, because again, inflammation is necessary, but because it's so repetitive, right? You're always moving your legs in those formations, right? If you're playing sport, you're constantly stressing that joint. Well, just like with like tendon pain and other inflammatory conditions we've seen, if you constantly stress that inflammatory process, it doesn't get a chance to complete. It just stays and keeps resetting that inflammation cycle. So if it's constantly being activated, it just never has a chance to really heal. And eventually it turns, instead of being a helpful thing and turning into an anabolic thing where you're actually trying to build new tissue or repair tissue, it turns into more of a catabolic, which means the joint's actually starting to degrade. And that's why you'll start to see, if this FAI is left unchecked, uncorrected, it can lead you down a road to hip osteoarthritis, because that cartilage just degrades, because that inflammatory response is like, hey, I'm trying to get rid of all this dead tissue, but there's more dead tissue every day.
It's kind of like, I was just telling this to one of my athletes today because she has a torn quad, and I was explaining to her why she didn't need crutches up until this point, but now she does. She's walking with a pretty bad limp, and it's like, okay, well, yeah, you can walk. It's very limpy, but
it doesn't look great.
What you're doing is every time you step on your leg, you are poking. Like if you had a bruise on your shoulder, you just keep poking it and poking it and poking it and saying, why is this not healing? But you're poking it.
Exactly.
And causing it more pain and discomfort in the whole process, and re-injuring that area.
Absolutely. So essentially, that's really the major concern when we talk about FAI, is obviously the pain that can be associated with it, but it's really with what we know what FAI does to the cartilage and how it really has an effect on how it develops and how it can degrade later, osteoarthritis and labral tears are a big concern with FAI. So that's really another reason why we need to really address this appropriately.
Okay, so we just talked about FAI a lot, but let's get to the point before that. Like, I have someone who I think has FAI, or how do I figure out if someone has FAI?
Yeah, so like I was saying at the beginning, the diagnosis for FAI is actually a little more complex than what you would kind of think, or what maybe we've kind of learned in school. The diagnosis of FAI is really based on 3 different kind of findings. They use radiographic findings like X-ray, which is very common. There's different formulas that they can run looking at different angles of the femur, angles of the pelvis, but also MRI and CT scan can be used. And they're probably going to want those to make sure that we're not seeing labral tears, which can be very prevalent with FAI, or seeing cartilage damage. The next thing that you'll want to use is really going off of symptoms, right? I mean, we're always going to take a history and see what they're feeling. And really what you're looking for is pain with prolonged sitting, or actually rising from sitting. They can have pain with prolonged crossing over their legs, right? You're basically creating an impingement there by that adduction, possibly internal rotation as well. Specific motions for creating pain, in particular, again, an adduction or an internal rotation. And they could also be complaining of clicking, catching, locking, giving way, or they actually feel the restricted motion.
That's like labrum.
Exactly. And then also your clinical signs. From what I've heard is like the classic C sign. Essentially, they just make a C around their hip. Like if they're just putting their hands on their hips, saying where the pain is, that can sometimes indicate FAI.
Also a labral tear.
Exactly. Interesting to see the common findings between the two.
Mm-hmm.
They may also have external rotation compensation when they try to actively perform hip flexion. They may try to externally rotate to help clear that bony malformation in order to perform that movement and avoid pain. And then as you're evaluating them, they could have restricted hip internal rotation on that affected leg compared to their unaffected leg. So, of course, the athletic training students will appreciate this. We gotta talk about special tests. Right? That's everyone's favorite thing.
I don't know about that.
So, as with most special tests, as we've learned over the years, is the evidence is really iffy on if these special tests are really good for identifying FAI. And two classic ones that most people like to use is, of course, FADIR. So that's the flexion, adduction, internal rotation. And it has a sensitivity of 80%, specificity of 24%. Some studies also say sensitivity of 94% and then specificity of 9%.
That's a big difference.
It's a big difference. But also, what we like to highlight, if you're not really comfortable with the whole sensitivity specificity thing, I know I have to keep looking at it all the time to like, it takes me a minute. I'm like, this one, spin, snout, what, right? So essentially the sensitivity is if that test is negative, you can assume that FAI is out. So if you do FADIR on someone, you have a pretty solid chance that if they didn't have pain with that, it may not be FAI. But the problem is the specificity is also really low. So if it is positive, you can't confidently say that, oh, the pain, the positive and the pain because of this test is because of FAI. It could be a host of other things.
So FADIR is really good for ruling it out?
Yes.
Got it.
So the next test is actually very similar to FADIR, and it's the anterior impingement test. So the difference is, from the literature that I looked, that FADIR is really supposed to be tested in maximal flexion and then maximal internal rotation, whereas the anterior impingement test was used at 90 degrees of hip flexion, and then you internally rotate as well.
So essentially, you're just checking hip internal rotation.
Exactly. That's basically what you're doing. And what's funny is the numbers are basically the same. Sensitivity 80%, specificity 26%. Some studies say it might go up to like 96% for sensitivity and then 11% for specificity. So overall, these special tests really aren't good at giving you high quality information. I mean, obviously, I'm not saying don't do them, right? You can get some information because obviously if they don't have pain with it, you've ruled out a condition, right? I would also encourage you, when you're evaluating someone who you think may have FAI, it's also good to evaluate the labrum as well, using your scour test or any other test that you've used for labrum. That's always a good idea to look at as well.
So essentially, if I do FADIR and anterior impingement test, and they are both negative, then I have a pretty good feeling I can move on to a different diagnosis.
You could probably have a differential than FAI.
Okay.
So now before we start thinking like, well, I'm never doing these special tests or they're not valuable at all, another key component to looking at FAI is identifying restrictions in motion. In particular, those with FAI may have been shown to have restrictions in hip flexion, and the sensitivity for that is 51%, specificity is 68%, so a little more even, still not great. Same thing for internal rotation with the hip at 90 degrees of flexion.
I feel like I know we just talked about FADIR, but I feel like internal rotation should have a higher rule in factor.
You would think so. And like with the hip at 90 and just testing internal rotation, the sensitivity is 56, specificity 63. What I thought was very interesting is internal rotation restriction. So just having them laying prone, and then I don't know if you guys have seen it before where they're laying prone and they have their knees bent and you just basically put them in internal rotation. That actually has a really good specificity with 94%.
Wow. So with the hip extended. Or
Well,
like
neutral. Yeah.
Yeah.
It would
But
be
I mean,
neutral.
not flexed.
Exactly. And if they have a limitation on the injured leg, you have a 94% chance of saying that could be because of FAI.
So if you have someone who you think has FAI, basically lay them on their stomach, do the internal rotation with the hip at neutral, and you have a pretty good idea that if that test is positive, they have FAI.
Possibly, yes, that's true. But I would also say what I really hope to get out of talking about the special test and range of motion is combine them. Obviously, we're always going to do that as clinicians. We're not just going to do one thing and like, oh, well, that's it.
Oh, no.
Exactly. That's not going to go over well. So if you have someone who has pain with the two special tests, right, FADIR, the anterior impingement test, and then you're seeing these range of motion restrictions, you can improve your confidence and feel more comfortable saying, like, I think you might have FAI. I couldn't really find any literature that actually put like an actual like sensitivity specificity for when you combine special tests and range of motion, but it does have the potential to increase your confidence as a clinician to say, yes, I'm diagnosing this because I'm seeing these restrictions. I'm seeing this test as being positive. I'm very suspicious that it might be this. Because as a whole, individually, these tests really aren't great to give you the answer. Obviously, we would always love to have a test that's 100% sensitivity, 100% specificity. We don't have that. We have some pretty mediocre tests for these, but I think combining the mediocreness of all of them can really boost your confidence.
But then again, special tests are not all that jazz. So going back to the history, what sorts of things might you be hearing that kind of make you think, oh, hey, I should be checking for FAI?
A lot of it is what we talked about, what they would complain about, like the certain restrictions that they feel, the clicking, popping, the pain with those adduction movements. Other things that you can look for are patients with FAI have been shown to have decreased proprioception. And when you're testing, muscle strength, they'll have hip abduction and adduction weakness. So that's another clue that you can use to hint at they might have FAI.
Or a labral tear.
Which, again, those two go pretty hand in hand, and both of them do warrant referral.
Or if they have an FAI that caused a labral tear.
Exactly.
All right. So I have a patient. They were complaining about this history that you were just talking about. And then I did some special tests.
And range of motion.
And I noticed that they also had like decreased proprioception, some weakness in hip abduction, adduction.
Oh, I feel like I've heard this before.
I think they have FAI, but I want to treat it. What do I do?
So over the past, I'd say maybe decade or so, surgery's become very popular for this condition. And it makes sense, right? It's a bony overgrowth. Hey, you get rid of the bony overgrowth, it should fix the problem. So there's been a big debate between going surgical or conservative. It's still, obviously, no one ever jumps to surgery. So they still try to do a bout of conservative rehab. But what's really nice, and I mean, really all rehab kind of shares this, but the rehab between a surgical approach and the conservative approach essentially has the same pillars that they emphasize in the exercise program. They're going to, one, improve the postural alignment, right? If your pelvis and your core is all over the place, it's not leading to good mechanics at the hip. You're going to increase core strength and endurance. Similar thing. If you don't have the strength to keep your core or the endurance to keep your core for long periods, you're going to run into issues. And then they also want to increase the hip muscle strength and motor control, and then overall increasing lower body mobility. It sounds pretty basic, but it was very interesting to see that throughout the literature that even the conservative and the surgical management are still going off of these same pillars for this condition.
Yeah, I mean, obviously every person's going to be individualized, and we stress that a lot in our podcast, but I feel like I would love to try conservative first because if you are able to correct some of those things that were also causing this, if you don't do that with surgery, which you should be going to PT afterward anyway or doing rehab anyway, I just feel like that bony overgrowth is going to come back.
Yeah, absolutely.
And that has to be stressed to the patient.
Yeah, absolutely. And also, conservative management does have good outcomes, right? Like, so there's good studies out there that have looked at comparing surgical intervention and then doing just a conservative bout first. And it's important to note that both groups did improve. So it's not like one group improved, the other didn't. So you can still get really good outcomes from going conservative. But some of the literature has shown that the surgery has better outcomes in terms of pain, function, and quality of life. Not saying that conservative didn't. Conservative still improved. It was just surgery did better than the conservative approach. But what I thought was very interesting, right? The whole idea of doing the surgical intervention is, okay, well, we're getting rid of the bony overgrowth. That should improve the mechanics of the hip. There shouldn't be any more shearing. The cartilage should technically be healthier. What I thought was interesting in the literature, I found that the rehabilitation approach, doing the conservative approach, improved cartilage metabolism compared to surgery. So what that means is, at a certain point, rehab slowed the response from the cartilage. So it wasn't in such an inflammation, like turning over new cartilage, as consistent as the surgery group. So there was less stress to the cartilage.
So when the patients did rehab, they adapted, their tissues were able to adapt better.
Exactly. They didn't stress the cartilage as much, so it had a chance to heal.
So they stopped poking it.
They stopped poking the bear.
Ah.
Yes. I mean, obviously the group in the surgery did do some rehab, but the rehab group was a little more focused. It was a little more individualized compared to just kind of like the regular treatment that the post-surgical group got. So that is something to keep in mind. Obviously, the goal would be after surgery that you do an in-depth rehab, and that could probably affect those results as well. But I did think it was interesting that before we just say like, oh, well, if surgery's better, let's just do that one. Rehab has its place, and you definitely may get people who don't need surgery because surgery does carry a lot of risks. Just the surgery itself. And then obviously later we've learned that like those that have had ACL surgery have a higher likelihood of eventually getting knee osteoarthritis. So you're going in and cutting the joint to make the joint better. So that can carry risk as well. So if you're able to successfully complete this with kind of a conservative approach, it's definitely worthwhile. And you can definitely save the cartilage that way as well.
So going back to if we were going to focus more on that treatment and rehab, I just want to repeat these because sometimes it helps me when I'm listening to a podcast. Like we go over it so quickly and we don't touch back. But anyway, the pillars that we want to be focusing on are improving postural alignment. So really, can you go a little bit more in depth on what that means?
Yeah. So if you have the biggest thing is you want to identify the person if they have a higher anterior pelvic tilt, because that's just closing that anterior acetabulum more, right? So you're creating more of a flexion moment. So if you're able to get more of a posterior tilt, it should alleviate the stress there.
Okay, so focusing on that posture, especially in that anterior tilt, and then increasing core strength and endurance, which will also help in that anterior tilt.
Absolutely.
Correcting that.
Absolutely. And it's, you know, what's awesome is like when they talk about core strength, it's the same stuff that you hear about for like post-surgical or basic core rehab, right? Dead bugs, bird dogs, we're not reinventing the wheel. You have these tools that you can use, and they can be very valuable, one, in the conservative approach, but also early post-surgical.
TA, marching.
Yes.
I love those.
Absolutely.
Increase hip muscle strength and motor control.
So the motor control part, if you've heard our education episodes before, it's what we've stressed, right? We want to avoid that valgus, right? That involves internal rotation of the knee, right? Or like the hip internally rotating, creating the valgus motion at the knee. We want to avoid that because it contains internal rotation. And the hips may not be like necessarily weak in that case. It's a motor control problem. So we want to be able to control our hip joint as we're moving in space. And also what I found that was interesting was hip adductor strength after the arthroscopic surgery for FAI has a pretty strong role in eventually what kind of outcome these patients have. So we always talk about the glutes and we always talk about the hip abductors. Those are all very important. But the hip adductors also serve a strong role in hip stability.
Well, yeah, if you have too much of anything on one side,
Exactly.
then you're gonna have a deficit.
100%.
You're gonna be uneven.
Absolutely.
So that's why you want to do 4-way hip.
Yes.
So good hip muscle strength, and then lastly, increase lower body mobility.
Absolutely. And it goes back to the joint by joint approach. If a mobile joint isn't moving like it should, it's going to make a stable joint move more, and you don't want that, and that's going to cause breakdowns elsewhere, and then it changes how another joint's supposed to move, and it's all bad.
Yeah, I mean, just breaking that down, it's just a whole compensation problem.
Absolutely. And then it'll lead to stress at another area of the body.
Kind of like what we were talking about with Jordan and the shoes.
Yes.
Where he was saying that his patient had knee pain. They were given different shoes.
Fix the knee pain, but
they had back pain.
Because of the shoes.
Yep. So they just went back and fixed the knee problem in the first place.
Exactly.
So that's kind of the same thing we're doing here with lower body mobility. You want to make sure that the right joints, that if there's stiffness in an area, if there's tightness, you're addressing that so that it's not going up or down the chain.
Absolutely.
And that just goes back to the core strength too, because core is such an integral part of what it connects. It connects to above with the upper extremities, it connects to below and it has such a big role in the pelvis that core strength honestly is done for a lot more things than we think of.
Absolutely. And the core strength can help with the hip muscle strength as well. Studies have shown that if you have adequate core contraction, core strength, it actually enhances the muscle contraction for the extremities. So if you have poor core control, your hip musculature can't fire as optimally as it would. Whereas if you had that proper core control, now you're getting an optimal contraction from the hip. If your hip strong enough, has good control, it can control that head of the femur. So now it's not like rattling around in your acetabulum. And it's going to save the cartilage that way as well.
And this is also why I really like Pilates. If you guys have ever dabbled again in any Pilates exercises, is because Pilates really focuses on a stable core with movement in the extremities. And so that can be transferred functionally for a lot of things, because if you have a stable core, if you are able to move your upper body and lower body with your core being stable in these exercises, then you know how to engage that and how your body should be as you're moving through your sport.
Yes, absolutely.
Yeah, it just creates a great foundation.
Oh, definitely. And I think that's important going forward in any rehab, especially FAI.
Yeah, is there any other FAI fun facts that you want to share with us?
You know what? I want to leave it with an action item for you, babe.
That's my favorite.
Yep. I would say the biggest thing is, right, we already talked about like why FAI is dangerous, or I don't want to say dangerous, make it seem like it's the end of the world, but why it can cause problems and why we should be taking this very seriously. And we talked about how evaluating it can be tough and the tests for it aren't great. I think one of the most important things in this is really located in the treatment aspect of this episode, and understanding that rehabilitation, whether you're going the surgical route or the conservative route, is one of the most important things in the treatment of this FAI. Obviously, the surgery is important, and no one's ever going to doubt that that has huge benefits, but you can do the surgery, and if you have a poor rehab program set up for after the surgery, that's going to set you up for way more issues later on. So really, your outcomes, whether conservative or not, have a great rehab program, have something that hits those 4 pillars, and you're going to save your cartilage down the road. You may even save yourself from having to do the surgery. And I would argue not having to do a surgery is better than having to do the surgery.
Yeah, I would argue that too.
Oh yeah. And plus, if you go conservative, your athletes have no missed time.
Or if you start with conservative and then decide down the line that you need surgery, that's still an option too.
Absolutely. And the return to sport from FAI from FAI surgery is pretty high. I mean, it's around 90%. Pro athletes get up to 93%. And then some of them have said that like their pre-injury levels are around 83, 85%. Obviously, we want those closer to 100, but you see that's a risk when you're talking about surgery. And if we can nip that in the bud and have a good conservative program that gives them a chance to work, that might be more beneficial.
I agree. So Randy used a lot of research articles to put this episode together, as he does with all of our education episodes. So if you want to take a look at those, go ahead and go to our website, which is in the show notes or description below. Just scroll down and check out the article citations used for those. How many would you say we have around, Randy?
I think I'm sitting around about 20.
So if you want to know where to start your reading, start there. And then also we have a Facebook group if you guys want to talk more about FAI. That's facebook.com/group/AT Corner Podcast. There's only one question to get in. It's where did you hear about our podcast? And make sure you answer that, and then you'll automatically be added to the group. If you guys are here for the CEUs, make sure you also scroll down in the show notes below. There's a free option for the CEUs that we're just talking about here. Just make sure you complete the course evaluation and the course quiz.
Yep.
And then once you do that, you should be emailed a certificate of completion.
Absolutely.
And if you'd like to hear more about FAI, and if you'd like to get additional CEUs and a show outline, go ahead and go to that website they were talking about earlier. It's also in the show notes below.
Yes, link is in the show notes.
precisionat.com/homesteady-CEUs, and we will have all of those bonus content things up and running for you guys.
Yes, you can purchase this episode and the bonus content there, and you can also explore their website they have other additional CEU programming that's really solid. We were lucky enough to be on one of them as well.
Yeah, and if you want to get CEUs from listening to stories, that's on there. It's called 18 Notes on the Field. Any other home study CEUs you can get on their website for 10% off using code ATCorner. And pretty much all the rest of our fine print, all the fun stuff, if you guys are new, just head to our show notes. We've got lots of fun stuff down there.
Yes, absolutely.
You got anything else to add, Randy?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.